Hello, everyone. We will give it a minute to allow for people to come in and we will get started.
Hi, everyone.
Hi.
Sorry, it gave me a lot of issues to log in the first one, so I don't know what happened, but I'm here.
That's
Happy
great.
to have you on our
you.
side, Sudol.
Thank you.
For those who are joining, we're just giving it a minute for people to come in and we will get started shortly. Okay, I think we're good to go. So hello, everyone. Welcome to today's webinar hosted by GRAPPA and GRAPPA. We are delighted to have you join us today to discuss the highlights from the American College of Rheumatology meeting that just took place in Washington, D.C. My name is Lourdes Perez-Chada, and I will be moderating this session alongside my co-moderator, Dr. Fabian Proft.
Thanks, Lourdes. Yes, it's a pleasure being here again because I really enjoyed the format. Now we were just discussing the relevant highlights from psoriatic disease, mainly psoriatic arthritis, when we were in person at the ACR in Washington. But we want to bring it also to you and that you can contribute. And we will have some place for question and answers here today. And we have brilliant young GRAPPA members that were supervised by senior GRAPPA members and the selection and the preparation of their presentations. And I'm really looking forward to hear their highlights on 3 different topics divided into basic science, clinical topics, and treatment. And I think we can really look forward to what has been selected.
Wonderful. As we move forward through the presentations, feel free to put your questions in the Q&A section here of Zoom so that we can bring them up to the Q&A time slots that's been allocated to each of the presenters today. So we're going to start with basic science. And so for our first session on basic science, we are joined by Dr. Vinod Kumar. He's an assistant professor in dermatology from India with a research focus on molecular and cell biology. And supporting this session for the Q&A, we will have Dr. Siva Ray Chowdhury. He's a professor of medicine from the University of California and a senior GRAPPA member and an expert in basic science and rheumatology research.
Yes, Vinod, we are really eager to hear your insights. The floor is yours. We can start.
Yeah, thank you. Thanks a lot, and good evening and good morning to all. So today I'm here to discuss the 3 abstracts. The first is transcriptional changes in the formation of tissue-resident memory cells in the joints, and second, characterization of the tissue-resident memory T cells in autoimmune arthritis, a comparative study of psoriatic arthritis and rheumatoid arthritis, and the third and the last abstract was to psoriasis patient at the risk of psoriatic arthritis have increased level of circulating pro-migrated and dendritic cells. So with the first abstract, it is presented by the Magret group from the Boston, and they have discussed that how the transcription changes happens and there is a development of tissue-resident T-memory cells in the joints. So for this study, in the next slide, we will see that as we know that there is the T cells which resides in the healthy and the normal joints, and when there is any inflammation, the cells, the more T cells get recruited at the site of inflammation, they proliferate over there, and as the disease enter into a remission, the T cell gets settled down where there is formation of tissue-resident memory cells, and these cells, when get exposed again to certain insult, they will proliferate again and flare up the disease. And there are the many animal studies also that have shown that if we downregulate or elevate these tissue-resident memory cells, we can control the arthritis disease. So, but how these tissue-resident cells formation occur in the joints is still unknown, and this study is helping in dissecting that how these resident memory cells are formed in the joints. So in the next slide, for this particular work, the author have used over antigen based arthritis model, and they have done the adaptive transfer of the over antigen T cell isolated from the mice, and they have observed that at the day 7 of the injection of over antigen, there is a acute inflammation, and this inflammation resolved by the day 28. And if there is a re-exposure of these mice again to the over antigen, there is a flaring of the arthritis. So they have adopted a adaptive transfer model where they have isolated the CD8 and CD4 cells from the mice, and they transferred them into the arthritis flare mice model. And after this transferring, they have isolated the CD8 cells at the different days, day 3, day 4, day 5 and 6, and day 7 and 8 and 28. So these days are reflecting the different days of disease. And they, in the next slide, they have then they have analyzed these uh, CD8 cells for the transcriptomic profiling by using the single cell RNA-seq, and then they did the trajectory ancestry analysis to find their progenitor and to find the regulatory genes that derive this tissue resident memory cell formation. They have done the synovial organoid experiments. These are the in vitro one from by using the blood mononuclear cells. So in the next slide, that the result shows that there is the unique formation of CDT CDT resident memory cells that are similar to the CD8 cytotoxic cells, and these cells are mainly derived from the central and effectory memory circulating CDT cells. And further, in the next slide, they have shown that where they have done the gene expression studies, and they have shown that there is a increase in the expression of RENEX genes. Can you go to the next slide? That there is an increase in the RENEX gene, and this gene help in the differentiation of these tissue resident memory cells in the joints. And there is a increase, there is not increase, but there is a moderate expression of JFP683, ITGA1, and interleukin 7 15RA. So these genes are helpful in maintaining the expression of CD 69, 49, and the interleukin 15 that are very important to maintain the homeostasis of the joints and maintain the tissue resident memory cells. So if I conclude this study, so in rheumatoid arthritis joints, there is an increased accumulation of tissue resident memory cells that develop from antigen specific effector cells that are circulating in the blood. And this unique CD8 tissue resident memory cells development governs by the canonical pathways that involves the RNX3 and JFP63, ITGA1, and all these genes. Uh, and if there is a if we target these genes by therapeutically, then they can be potentially downregulate the formation of more tissue or the tissue resident memory cells in the joints. So with this, we can go to the next abstract where we are discussing the characterization of tissue resident memory T cells in autoimmune arthritis. It is a comparative study of the psoriatic arthritis and the rheumatoid arthritis. So it's from the Siva's group. So here they have the author has taken 3 different type of the patient. They have taken patient with the osteoarthritis, psoriatic arthritis, and rheumatoid arthritis. And they have isolated the synovial fluid mononuclear cell from these patients, and then they stimulated these cells in vitro, and they did the flow cytometric analysis to identify the tissue memory resident memory cells by using the specific markers like CXCR7 negative, 69 and 103 positive, and the CD8 cells, CD3 positive, CD4 positive, and CD8 cells. And further, they have also looked for their TS17 type phenotype, like whether these cells are prone towards TS17 differentiation or not. So this is the flow cytometric gating strategy they have used to identify these cells. And the first is showing that they have selected the negative CXCR negative cells, which are CD8 positive and CDR positive, and they further divided into a CD49 and 103 positive cells. So their study have found that most of the around 70% of the tissue resident memory cells belong to the CD4 positive cells. So in the next slide. So as we can see that in the rheumatoid arthritis and the psoriatic arthritis, there is a more CD4 positive tissue resident memory cells compared to the osteoarthritis. And as these author also looked for their TS17 phenotype, so they identified that most of the CD4 tissue resident cells which are present in the psoriatic arthritis patients are TS17 prone. They have the ability to secrete TS17 cytokines and cause or increase the inflammation in the psoriatic arthritis compared to the rheumatoid arthritis, which are not TS17 prone. Next slide. So if I conclude their study, so in this cohort of 3 different types of patient cohort where they have osteoarthritis, psoriatic arthritis, and rheumatoid arthritis, the author showed that there is a increase of tissue resident memory T cells, that is the CD4 and CD8. But in case of psoriatic arthritis and rheumatoid arthritis, there is a more dominance of CD4 tissue resident memory cells in the psoriatic arthritis. And when we compare their TS17 polarization or their ability to cause TH17 or IL-17 based inflammation, so it is a more dominated in the psoriatic arthritis patient compared to the rheumatoid arthritis patients. So can we go to the third? So is the third and the last abstract, and where I'm discussing that how the psoriasis patient at the risk of psoriatic arthritis have increased level of circulating pro-migratory dendritic cells, and this abstract is presented from the Chandrasekharan lab. So here the author studies the presence of migratory dendritic cell in the psoriatic patient and come with the development of psoriatic arthritis. Like after the development of psoriatic arthritis, there is a continuous but the slow immune cell polarization, and that drives the psoriasis into the preclinical psoriatic arthritis. But as this inflammation increases and with that time to cause silent inflammation and take disease to a subclinical level. With time and more secondary hits, this leads to the development of the psoriatic arthritis. So as the disease progresses or the inflammation progresses, there is a increase the psoriasis, the chances of for getting psoriatic arthritis are increases. So what are the factors which are responsive for this transition are not well known. So this study targeted the dendritic cells, that how they are contributing in the development of a psoriatic arthritis. Can you go to the next slide? For this, the author have recruited patient with psoriasis and psoriatic arthritis. They have characterized these psoriatic arthritic patient as a high risk psoriatic arthritis group and low risk psoriatic arthritis group. So high risk is defined with the presence of any two uh, risk factors, and the low risk who don't have any type of these risk factors. They have isolated the peripheral blood mononuclear cell from these patients, and then they did single cell RNA sequencing followed by flow cytometry and dendritic cell migration assays. Next slide. Yeah, so the single cell RNA analysis showed that there is a clustering of dendritic cells in the psoriatic arthritic patient who are at the high risk of psoriasis. There are two patients of the two low risk psoriasis. 4 patients they have included in the high risk psoriasis, and the 2 patients are with the psoriatic arthritis. So they further in the next slide they have shown that they did the cell type abundance analysis based upon the RNA-seq analysis, and they have identified that in the high risk, that's the bar represented with the blue color, that in the high risk psoriatic arthritis patient, there is a more accumulation of classical dendritic cells compared to the low risk and the psoriatic arthritic patients. So considering the importance of these classical dendritic cells that will help in the differentiation of naive T cells into the Th17 cells shows that these dendritic cells have a potential impact in the development of or progression of high-risk psoriatic patient towards the psoriatic arthritis, because the psoriatic arthritis is more characterized with the IL-17 or Th17 phenotypes or inflammation. So in the next slide, they have they have isolated the classical dendritic cells from these patients, and they performed the RNA-seq analysis, and they have identified that these classical dendritic cells are expressing more CXCR4 receptor, and they confirm this expression by using the flow cytometry analysis, and they here also shown that there is an increase of CXCR on the high-risk psoriatic patients' dendritic cells. So this expression of CXCR help in the migration of dendritic cells from circulation to a particular tissue or the site of inflammation. So in this case, as the site of inflammation are the joints, so they assume that these dendritic cells circulating or migrating from the circulation to the joints, and they causing the inflammation over there. So in the next slide, they did this migratory analysis by using the transwell migration assays, and they identified that yes, the patient who are at the high risk of psoriatic arthritis, their dendritic cells have the more mobility or capacity to mobilize from circulation to the joints compared to the patient who are at the low risk of development of psoriatic arthritis. So if I conclude this study, so as we know that the dendritic cells are playing a central role in modulating the inflammation or immune cell homeostasis at the site of inflammation. They can drive the Th17 differentiation, Th1 differentiation, they modulate the other dendritic cells, and also alter the expression of beta defensins. So so their importance in causing inflammation or arthritis is very important. So as a disease progresses from low psoriasis to the psoriatic arthritis, these dendritic cells start increasing the expression of CXCR4 with increase in this receptor expression drives these dendritic cells to localize to the joints where they can differentiate or polarize the naive CD cells into a Th17 cells and produce IL-23 that also helps in the development of Th17 cells, and all together they will develop into the psoriatic arthritis. So this abstract is mainly highlighting the role of dendritic cells, that how it can these cells as the disease progresses, they also migrate to the joints and cause a psoriatic arthritis over there. So with this, I'm just finishing my presentation. So before going into the discussion, I would like Dr. Shiva to add some more information of on these tissue-resident memory cells and dendritic cells, that how much important they are in this disease.
Thank you, Vinod. I think it's a very good presentation. So the TRM, tissue resident memory T cell subpopulation is, relatively new to our clinical immunology. Basic immunology, it is known for probably 1 decade. And these TRMs are important in various ways, like for cancer and infections. We need these TRMs to control that. And whereas in autoimmune diseases, these TRMs are sitting there and making those potential cytokines and causing the disease. So in that respect, the chronicity of the disease and relapse in autoimmune diseases.
Okay, thank you so much, Vinod. Thank you, Siba, for the great presentation. For the whole audience, please feel free to type in your questions in the Q&A section so we can discuss your questions here. Vinod, from my perspective, I would like to know, and this is also shown here in the discussion part, because you were quite optimistic that this could be a potential new treatment target in the future. Can you maybe elaborate a little bit on where we are at the moment and how close are we to really have this as a therapeutic option in our pocket?
By altering the gene expression, like by using the RNX or other genes inhibitions, we can modulate the differentiation of these tissue-resident memory cells. But I'm not much aware that is there anything is available right now that can alter these pathways so specific, to so localized to the joints or at the site of inflammation in the rheumatoid arthritis. So I think it is still maybe in coming years maybe we can get more molecular targets, and that can. But I think is a very important to know the pathways of differentiation so that they can be inhibited very specifically. So this study is much more important in that way. As
Yes,
I
thank
think
you.
so.
And maybe also because, I mean, currently we are still seeking for a very good biomarker for patients with skin psoriasis and the very high likelihood or sure progression to PSA in the future. And you were also speaking about potential new biomarkers here. And yeah, maybe you can share the clinical relevance that we have at the moment and give an outlook into the future. What could it lead it to?
Yeah,
Sorry, there was
the last
it got
abstract,
it got
where
disconnected for a second. So so the thing which I was trying to say, that the regulation of the TRM in psoriasis, psoriatic arthritis, rheumatoid arthritis is important. And one thing we can see, you see the efficacy of a cytokine like anti-TNF is lasting only for weeks. But when we are using anti-IL-23, which this TRM gets regulated, is lasting for 3 months. So, more work on this area, identifying more specific marker for TRM in respect to their apoptosis and growth could be a interesting area for therapy of T cell mediated autoimmune diseases. Okay, Fabian, you can continue.
Thank you, Siva, for those comments. Vinod, did you want to say any other final comment?
Yeah, I think as Fabian was asking, about the biomarkers. So I think, in the last slide, last abstract, like the identification of the migratory dendritic cells in the circulation might be, like another cell-based biomarker that can be analyzed, like in the circulation. and by using flow cytometry that is very conventionally available everywhere, and we can if it adds into predicting the progression of psoriasis into the psoriatic arthritis. So I think it could be a maybe we need more data, like more clinical data to make it more accurate or more possibilities to increase the possibilities of such biomarkers.
Great. Thank you so much, both of you, for this presentation. And now we're going to move on to clinical topics, right?
Yes, this is correct. So next we move to clinical topics, and I'm really looking forward to the presentation from Dr. Yusuf Can from the Department of Dermatology at Gazi University in Ankara, Turkey. And Dr. Edek is a young GRAPPA member and a full GRAPPA member with expertise in immune-mediated skin disease, including psoriatic arthritis, psoriasis, but also HS and vitiligo, and the use of ultrasound. And he was supervised by Dr. Sibyl Aydin, and I'm really looking forward to have her also contributing to the panel discussion later on. She is a professor and director of research at the University of Ottawa, and she has a very strong focus in musculoskeletal ultrasound. This is where we also see Sibyl very recently at the ACR meeting. And without any further ado, I think the stage is yours, Yusuf, and you can proceed with your presentation. Thank you.
Thank you. Hello, everyone. First of all, I want to say thank you to GRAPPA and Young GRAPPA team for gathering all of us in this great meeting. And I hope this meeting will be very beneficial for all of us. With my mentor, Professor Dr. Sibel Aydin, we made this presentation, and I would like also to express my gratitude to my mentor. In this slide, you can see our disclosures. And if we talk about our presentation plan, we planned two different groups. The first one is equality, diversity, and inclusion, EDI. The second part was imaging clues for psoriatic disease. These two groups were very important recently in the psoriasis and psoriatic arthritis. If we look to first part, we will speak about equity, diversity, and inclusion in psoriatic disease. And we will speak about impact of race on ethnicity in the psoriatic disease burden and racial and gender disparities in psoriatic arthritis in clinical trials. In the imaging part, we will talk about naive-fold videocapillaroscopy in psoriatic disease and how to define enthesitis by ultrasound. If we continue, in the first part, we are starting with the study from the Christopher Jenkins. Our first study was the study evaluating racial and ethnic groups differences in the burden of the psoriatic disease. In the racial and ethnic group orientations, we can say non-white patients having more extensive skin disease, higher disease activity, frequent axial involvement, and more comorbid disease. Also, they got delays in the diagnosis and less use of biologic medications. And also, I can say, if we look to the literature, we can see very restrictive and very low data on racial and ethnic differences on psoriatic disease burdens. This study aimed to evaluate association of neighborhood social deprivations and disease burden amongst the racial and ethnic subsets of psoriatic arthritis patients. This study was made based of RISE registry, Rheumatology Informatics System for Effectiveness, and in the study, demographics, disease activity, social deprivations, and treatments overall stratified by race. If we talk about the results, they found 21,429 psoriatic arthritis patients, median age calculated as 55, and predominantly female, and obesity was present in 56.1%. And if we talk about the high deprivation was greatest among the Black patients with 25.7%. Also, Black patients had high disease activity more often with 40.2%. After our first study evaluating effect of racial and ethnic group differences on the psoriatic disease, we will speak another study, and in this study aim to evaluate racial and gender disparities in the clinical trials. In the study, they made retrospective review of psoriatic arthritis in the literature from phase 1 to phase 4, and data on racial distribution of participants, gender distribution, trial phase, location, and year were analyzed. When we looked at the results, they found 84 clinical trials related to psoriatic arthritis and 91.6% from Europe or USA, and racial distribution reported in 60.7% of the studies. And if we talk about studies, they found 15,266 participants, and many of them with 85.1% with whites. If we talk about after these two studies, we can say that disparities exist for Black patients with psoriatic arthritis who have more prevalent high disease activity and high social deprivations. Only 60.7% of psoriatic arthritis studies had racial distribution published, and decreased representation of African American population in clinical trials. Understanding of the unmet needs in the field of psoriatic disease requires recognizing and researching the heterogeneity of the disease, including EDI. After EDI, in the second part, our presentation, we will focus on imaging methods in psoriatic disease. And in the imaging section, first of all, there will be a study examining nail involvement, which is one of the most important and challenging involvement of psoriasis. And in this study, we will talk about nail fold video capillaroscopy. Nail fold capillaroscopy is a very common method to use in systemic sclerosis and primary renal. But what about psoriasis? Is it common? We can say no, it's very low used method. And in the study, they want to evaluate findings of nail fold video capillaroscopy in patients with psoriasis and psoriatic arthritis and their association with clinical features. In the study, they collected 39 patients with psoriatic disease, 29 with psoriatic arthritis, 10 with psoriasis, and also they included 28 healthy controls. If we talk about disease severity, 61.5% of patients had psoriatic activity recording to PASI more 10, and 55.2% had active psoriatic arthritis according to disease activity of psoriatic arthritis. Also, if we looked at nail involvement in the patients, 58.9% had nail psoriasis. When we looked the results from the study, they found very different results. And they found that crusted capillaries, tortuous capillaries, bushy capillaries, more common in psoriatic disease. Also, one of the important part, avascular area was more common in the psoriatic disease. And in this study, they didn't find any differences between disease activity or nail involvement. They found only differences between psoriatic disease and control groups. In this picture, I will show some of the capillaroscopy figures to you. In the figure A, you can see normal atypical pattern with frequent crossed capillaries. In the B, multiple microhemorrhages, and in C and D is very specific for the study. They named as psoriatic pattern, which contain multiple bushy capillaries with basket-like appearance, borderline low capillary density, and avascular areas. In the conclusion, we can say major nail fold video capillaroscopy abnormalities frequent in the psoriatic disease, and psoriatic arthritis and psoriasis patients exhibited same frequency and types of nail fold videocapulariscopy abnormalities, irrespective of the activity status and presence of nail involvement. And also, again, I'm replying frequent distinctive bushy capillaries, bordering low capillary density, and avascular areas is trio of the psoriatic pattern, which found in this study. Following the nails, if we talk about the joints, another important involvement of the psoriasis, we will speak a study from Caroline Pigon, which evaluated enthesitis. In this study, and if we firstly talk about enthesitis, enthesitis is considered a hallmark of psoriatic arthritis. However, data on frequency and consequences of enthesitis are conflicting. In the study, they want to analyze clinical enthesitis in psoriatic arthritis, including its prevalence, scores, localizations, through a systemic literature review and meta-analysis. They made this study as systemic review in the PubMed from January 2010 to June 2023 with patients psoriatic arthritis, adult patients. And data collected at baseline included prevalence of the clinical enthesitis, scores used assess the enthesitis, number of enthesitis involvements, localizations, and impact of the enthesitis on the patients. And when we look at the results, in the study, they evaluated 84,262 psoriatic arthritis patients from 212 studies. 24 was randomized control trials, and 164 were observational studies. The prevalence was higher in the randomized control trials than observational studies, 70.1% to 30.4%. In the studies, they mainly use Leeds enthesitis index in 63.7 of the studies, and the most common sites for enthesitis is Achilles tendons, followed by lateral epicondyle and plantar fascia. And also we can say the pooled data, was found that 48.1% enthesitis was present in these studies. Following this study, if we talk about ultrasonography, which is an indestructible imaging tool in dermatology and rheumatology practice, in this study, we will talk about ultrasonographic analysis of enthesis. Study presented by Andrea Lucas Ribeiro. Clinical enthesitis occur in 30 to 40% of psoriatic arthritis patients, but its clinical diagnosis is challenging due to similarities and non-specific pain. Despite some standardizations of ultrasonographic analysis, a unified definition for inflammatory enthesitis remains vague. This study aimed to develop data and expert-driven diagnostic criteria to differentiate inflammatory enthesitis at the single enthesis level from non-specific sonographic findings. In the study, they evaluated in the ultrasonography hypoechogenicity, thickening, aeration, bursitis, enthesophytes, Doppler signal, and calcification. And they give some points in this analysis and grouped patients as definite enthesitis, undefinite enthesitis, and unremarkable. In the other results parts, they found that after evaluating the ultrasonography analysis, 32.2% of the patients classified as definite enthesitis, 23.3% as definite not enthesitis, 44.5% had uncertain. And they found that definite enthesitis patients' scans had more elementary lesions compared to others. Definite enthesitis scans had combination of 4 and more elementary lesions. But uncertain and not enthesitis groups had 3 or fewer elemental lesions. And if we look at the other results of the study in this part, they found that in this duet study, scoring elemental lesions was significant differences, highlighting in differences of hypoechogenicity, thickening, and power Doppler ultrasonography was common in the definite enthesitis group. Following this study, we can say that the presence of inflammatory elementary lesions drives the opinion towards categorizations definite enthesitis, particularly when high-grade power Doppler signal is present and when 4 and more elementary lesions are combined. Isole and enthesitis, common in the general populations, do not indicate inflammatory enthesitis, and these initial insights will form basis for an inflammatory enthesitis definition. And following the conclusion of our 2 enthesitis imaging study, we can say enthesiology and enthesitis are not synonyms. The prevalence of enthesitis varies depending on the tool used to assess, and ultrasonography can help to differentiate enthesiology from enthesitis, particularly when the high-grade power Doppler signal is present and when 4 and more elementary lesions are combined. And that's where all I can tell, and in the question and answer part, we can talk and more.
Wonderful, Dr. Redek. Thank you so much for that wonderful presentation. And we have here a question from Dr. Atul Diodar. So he says, do we know whether the prevalence of psoriasis and psoriatic arthritis is different in white versus black versus Asian population? Which genes are important for the differences, if any? Do you have any comments on that, you or Dr. Yeah.
I can say in the study, they didn't make any comment in this area, but genetic involvement is very important in psoriasis and psoriatic arthritis, and some common genetic ways are important for this area. And I can say in the other studies, we can find these differences.
Yeah.
And maybe I can just also because I think this was one of the most important takeaways from my perspective on your first presentation, the first abstract that you presented, is that we have to assess where they are coming from, which genetic background, which ethnicity they are referring to. So I think this is very important, because only when we are collecting this data and are sharing this, we will be able to really make any specific analysis. And I think what we can see clearly from the scarce data that is out there is that there's an underrepresentation of certain ethnic populations. So I think this is also something that we all have to drive forward in the future, to increase the number of patients from underrepresented populations. Happy to hear your thoughts on this.
Yeah. So just to add one thing, and to like, it's not reported in this study. These studies were not prevalence studies, but yes, white people are reported to have high prevalence of psoriasis compared to Asian populations, compared to African Americans or Black populations. And probably the reason is the reporting bias. If you don't see something, it doesn't mean that it doesn't exist. It may just be our physical exams may not be good enough, or our awareness may not be good enough. So there is a difference in the prevalence reported. And to the genetic differences, there are some genetic differences reported, again, not based on these studies, but the HLA-CW6, which is a major risk factor for skin psoriasis, is reported to be more common actually in the African population. Again, that's interesting because it's a risk factor for skin psoriasis, but also within psoriasis patients, it's a reduced risk factor for moving to psoriatic arthritis. So it absolutely is interesting in terms of collecting the data, because it's such a heterogeneous disease. Unless we really understand all dimensions of it, we're never going to be able to solve it. And EDI seems to be a major angle, as Fabian was saying.
Thank you. Siva, I saw your hand raised. Did you want to make a comment too on this topic?
I think Sibyl has answered it. Yeah, CW6, that's much more common in Caucasians, and especially, Atul has raised the question in Chinese population, is it the same? It is much less, and that's why, this genetic background makes a difference in different races. Thank you.
Great, thank you. And then there's another question about the clinical utility of nail capillaroscopy when assessing patients with PSA. So do you have any thoughts about on which situations would we be using this technique in the clinical setting with patients, right?
I can say my mentor, Professor Dr. Sibel Aydin, had very good comment on this our question. We had some conversation about the study, and she said maybe these findings on capillaroscopy can be some precaution for the psoriatic arthritis development in psoriasis patients. And I'm sure she has some more comment to say.
Absolutely. So I don't think that information can be carried to the clinical practice right away. So I think it's still a research question. But I personally found it quite interesting because we know that the nail bed is a very vascular structure. And this study shows that it becomes avascular in psoriatic disease more often. And actually, that's something that we published a couple of years ago using the ultrasound, because when we compared psoriatic disease versus healthy controls, psoriatic disease patients had less vascular ultrasounds. So in rheumatology, we're always super excited to see the Doppler signal when we see that it's the eureka moment. It means there is inflammation, not in case of nail disease. And I find it helpful for us to have another clue for the pathogenesis of the psoriatic disease, because we know that nail disease is important. If the nail is becoming avascular, that may be an important signal for us to go after to better understand the pathogenesis. And all of the clinical trials in psoriasis, it's so hard to conduct a trial to understand the predictors of PSA within psoriasis patients. And all studies are trying to identify a high-risk population that's going to progress to PSA to find the predictors. So maybe that's another predictor. Maybe that's another angle that we can use for selecting the high-risk patients. But all of them are research questions at this point.
And in fact, there is a paper that was published describing these nail changes as predictors of psoriatic arthritis in a longitudinal study. And so it had a larger cohort than the one that we saw in this abstract. So they found two things. They found that it was a predictor of PSA, and also that it was associated with disease severity, which in this case they didn't. But maybe it's also driven by the small sample, right? So I think that there's much more to investigate and flesh out from this area. So super interesting. Thank you for bringing this. Any other questions on this session?
Yes, I see that Atul has his hand raised. Atul, you're kindly invited to the discussion.
Yeah, thank you. This is fascinating, the nail disease and the relationship between nail disease and how that can predict development of psoriatic arthritis, as well as this avascularity that has been mentioned by Sibel and by Yusuf. Several years ago, it was shown by Dennis McGonigal that the nail bed is the extension of the extensor tendon, and which goes up from the distal DIP joint into the nail bed. And that's why one of the things that has been noted is that if somebody has to differentiate between DIP arthritis, between osteoarthritis affecting the nail, osteoarthritis affecting the DIP joint versus psoriatic arthritis affecting the DIP joint, you can look at the nail. If the nail is involved, then the DIP arthritis is in fact psoriatic, because if the nail is not involved, then the DIP arthritis is osteoarthritis. And this was basically thought to be because the inflammatory cells actually travel along the extensor tendon into the nail bed. But that brings a question that in patients who have purely lower limb psoriatic arthritis, they only have a knee joint and an ankle joint and Achilles tendon and plantar fascia, but nothing in the upper extremity. in those patients also, would the nail capillary changes in the fingernails are going to predict, uh, or rather, are they any? Do they correlate with psoriatic arthritis development? Let me phrase it another way. In psoriasis patients who are probably going to get lower limb extremity psoriatic arthritis, would nail capillary changes predict development of psoriatic arthritis when they may not even get psoriatic arthritis in the hands? I would have thought that the changes in the nail should really correlate with DIP arthritis, hand arthritis, but not knee arthritis, not ankle arthritis, not plantar fasciitis. I mean, it's
I'm going to raise a hypothesis to answer your question based on my thoughts. So when I was working with Dennis McGonigal on the extensor tendon enthesitis project, so we basically started the idea of, is nail disease more common in patients with extensor tendon enthesitis? So we had patients with nail disease, without nail disease, healthy controls, and we blindedly scored the extensor tendon findings and found the connection between the two. And then we wondered, is this a systemic enthesitis process, or is it just a local response? So we actually did another study looking at patients with different stages of psoriatic disease, and we looked at the large entheses that are remote from the nails. And we found that there was a connection between the two. So we said that this is an enthesitis process, this is a systemic burden of disease, which is also represented by the nail disease. We don't have a causality, like we don't know which leads to what, but the large enthesis is also impacting the nail changes. So I'm guessing from that angle, the joints are also connected to the synovial complex. I'm guessing that there might be a connection between the large joints and the nail vascular changes as well, but it's just a hypothesis.
fascinating. Thank you. Thank you very much.
Thank you.
And I think we should definitely take the advantage that we have one of the authors that were cited in your presentation just now here, and invite also Andre on the stage, because I think this is a unique opportunity that we have one of the presenting authors within our group. And when speaking, maybe Andre, you could just share the key takeaways from the abstract that was just cited.
Thanks, Fabian, and thanks, Yusuf, for presenting it. So far, it's still preliminary stages for the development of the new definition of inflammatory enthesitis. But so far, the key takeaways are that, first, you need to have a minimum combination of elementary lesions within a single scan to really be sure that it is inflammatory enthesitis and not just some minor changes secondary to other mechanisms, such as obesity and metabolic syndrome. The Doppler really drives the classification, especially if you have a grade 2 or grade 3 power Doppler that is close to the bone cortex, and again, associated with at least one other elementary lesion, because you can have a lot of power Doppler also after a run or in a tendon that is repairing a minor tear. You can have a lot of Doppler without other changes. So we really need to have that Doppler associated with other elementary lesions. And the same thing goes with severe structural changes, like having a large erosion, as long as it is associated with, combined with other elementary lesions. And one of the most important key takeaways is that everything in the due clinical context. So always use the ultrasound to complement your clinical assessment to have the most accurate impression of the case. If Sibel wants to complement, she's also co-leading the project.
Yeah, I fully agree. I think just one last thing to add to that on my end is similar to enthesalgia. So we don't just assume that there is one single enthesis. Like when we find tenderness, it means we need to increase the therapies, like immunosuppressive therapies. We always take into consideration what we had found on the physical exam. That's also true for the ultrasound. I don't think there is such a black and white definition of this is enthesitis, this is not. It should be incorporated into our clinical judgment.
Exactly.
Oh, you're muted,
You're
Fabian.
muted again.
Sorry, guys. Yes, we have the opportunity, and I saw that Martin de Witt, our patient research partner, and valued GRAPPA member has contributed in the chat. Martin, maybe you want to join us here in the panel discussion and raise the question that you were just writing in the chat as well.
Yes, this is a remark about the equity issue that was presented in the first two abstracts. I think we all know that there is an issue here. And I know, and 9 out of 10 papers that I read, if you go to the discussion sections, they all have this statement about the limitations of the study, which is always the diversity in the populations. But it's never changed over the last 10 years. We keep on adding this issue in the papers that we write. It's always, and I think there will be a moment that we don't have an excuse anymore for not becoming more inclusive. So I think also now we have the data. What does that mean for our clinical practices? How are we going to increase and improve the inclusiveness of our studies? And also, I'm wondering, is GRAPPA an organization that could help to promote and support this call for action?
And Atul has just agreed with everything you said in the chat function, and it's the same for me. And again, I think we should not just all nod our heads and say, yeah, we agree, but I think it's time to take action. And I think GRAPPA is also the right organization doing that, because also this webinar today is going in the direction to try to bring the message that was presented at the conference at the ACR to a unique, specific population of researchers, to bring this word to the people and out to you guys. And it will be also available for on-demand purposes later on the GRAPPA website. But still, I think it's something, and as said, I think the most important part is that we start collecting the data, because only when we see the data in any research project about the includes patients and race and ethnicity, we can make our assumption for the generalization to the wider population or to our specific population. But I also agree that I think this is something that we could bring back to the GRAPPA leadership if there are any potential opportunities. And Martin, I know that you are the perfect person to drive this forward as well. Together. But I saw first Atul had his hand up and then Sibyl.
No, just a quick comment is that, and this is not an excuse, but what I find here in Portland, Oregon, at least, is the reluctance on part of minorities to participate in clinical research. And this is not an excuse. We certainly need to promote participation in research, but United States especially has unfortunately bad history with Native Americans as well as African Americans participation in research, and sometimes it was forced on them in the past, and those scars still remain and they run deep. I do a clinic in Native American population in Central Oregon 4 times a year, and I tried to enroll patients into clinical trials, and I had such severe resistance from the tribes to participate in the research, to look at axial spondyloarthritis for the matter. And again, this is not an excuse. We certainly need to, there is more education needed, etc., etc. But that is one of the things, at least in this part of the world. The second point I want to raise very quickly is we definitely need epidemiological studies to find how common this thing is. And that was my very first question in African Americans. To give an example in a different way, lupus and lupus nephritis is known to be worse. The outcomes are worse in patients with patients who are Afro-Americans or African descent. And a lot of work has been done in places like Baltimore and eastern part of the United States, where there is much more bigger population of African Americans. Also known that Hispanics have worse outcomes. We don't know anything as far as, I don't know. I shouldn't say we. I personally do not know how common it is in African Americans. I do not know whether the outcomes can be worse, mainly because they don't really get the care that they need, etc. but this needs to be done on a population level. We did some similar study in axial spondyloarthritis, and we know what the HLA-B27 prevalence is in whites and African Americans and Mexican Americans, and the prevalence of axial spondyloarthritis, etc. But there are no big studies that I'm aware of that kind. And unless we have the population, we don't know the extent of the problem to start with. And you're right. And GRAPPA, this is a great call for waking up for GRAPPA, and something needs to be done.
Great. And a final comment from Sybil, and we will move on to the last session.
Yeah,
If that's
I'll
fine.
be quick.
Yes.
I
No.
fully agree that this is a really important issue, Martin and Atul, that there's not an excuse. We have to step up. And I think this was a wake-up call for the last couple of years that we started noticing more and more. And it is actually becoming a part of our discussions in every GRAPPA meeting, and we should do more. And I fully agree with that indigenous population. That's a common issue that we face in North America. How the axial spondyloarthritis is common, and we cannot recruit them to clinical trials because they are afraid of being a part of the research program. So I think the attempt should require a sociological approach as well. It's not just scientists that can deal with it. It's the sociological experts that needs to come on board to help us, as well as some local leaders that's going to help as well. So I think this is a GRAPPA, this is under the umbrella of GRAPPA's missions. I think we should face that and invest in it because I think it's a responsibility.
Perfect. Well, thank you again, Dr. Edek and Dr. Aydin, for those wonderful presentations and everybody who just participated in that exciting discussion. And we're going to move forward now with the last session. So now we're going to be talking about treatment in psoriatic disease. This will be presented by Dr. André Lucas Ribeiro, a rheumatologist from Brazil at Hospital de Clínicas de Porto Alegre and Hospital Moinhos de Vento. Dr. Ribeiro is the current chair of the Young GRAPPA, so congratulations on your new achievement. And he specializes in ultrasound applications in spondyloarthritis. And for the Q&A session, we will be joined by Dr. Atul Jodar, a senior GRAPPA member, professor of medicine, and medical director of rheumatology clinic at Oregon Health and Science University. So the room is yours. Please go ahead.
Hello, everybody. First, I'd like to thank the organizing team for the opportunity of being here and for helping me with the selection of abstracts and development of these slides. But also, I'd like to apologize because I know that a lot of great presentations are not going to be mentioned due to time limitations. These are our disclosures. Can go next. So the first abstract that I would like to mention is a post-hoc analysis of bimekizumab efficacy regarding uveitis. While IL-17 has been implicated in the pathogenesis of uveitis, we all know that the studies with IL-17A inhibitors were somewhat disappointing, and currently we have very few options to treat uveitis. So at ACR 2024, they presented bimekizumab data, which works slightly different in the sense that it also inhibits IL-17F, so it's a dual inhibitor. So this was a post-hoc analysis of the phase 2b and 3 trials of AxSpA and PSA, including a total of 6 trials with 2,500 patient years of AxSpA patients and 3,600 patient years of PSA patients, comparing the exposure-adjusted incidence rate of uveitis over time. Next. And in summary, here's what they found. At figure 2, the one on top, we can find the overall estimate incidence rate in AxSpA patients over 100 patient years. So the overall incidence was 1.3. When looking at patients with prior history of uveitis, it was 4.8. And with patients without history of uveitis, it was 0.6. This is important to consider that the usually prevalence of uveitis in AxSpA can go up to 25%. When looking at the lower figure, the PSA one, we can see that the overall incidence was very low, 0.1, which goes with the knowledge that PSA patients do have lower incidence of uveitis. And when looking at specifically patients with prior history of uveitis, it went up to 2.4, but it's still lower than the normal prevalence of roughly 7%. And in patients without uveitis, it was again 0.1. Importantly, only one of those cases led to treatment discontinuation. So as a take-home message of this study, which again is a post-hoc analysis, the incidence of uveitis was low among bimekizumab-treated patients with AxSpA and PSA, which raises possibility about bimekizumab's effectiveness for uveitis compared to other IL-17A inhibitors. Of course, specific studies will be needed to really answer that question. Next. The second abstract I'm highlighting is about sonelokimab, and now we'll start a series of abstracts about newer medications. So sonelokimab is a novel nanobody that inhibits IL-17A and F, potentially offering a better tissue penetration since it has a much smaller size, as you can see in the figure, when compared to bimekizumab. So sonelokimab have roughly 40 kilodaltons compared to 140 of bimekizumab. This was a phase 2 trial, multicentric, randomized, double-blind, placebo-controlled dose-ranging study, meaning that they tried 3 different dosing protocols. And the primary endpoint was reaching ACR 50 at week 12, which was presented at EULAR 2024. And the novelty at ACR 2024 was the data for week 24. Next. So going to the results, we can see that the ACR 50 response on the left continued to improve from week 12 to 24, reaching roughly 60% across the different dose regimens compared to 55% adalimumab. And we could also see sustained or enhanced response for all other outcomes, including MDA for week 24 and the combined ACR PASI responses. Importantly, sonelokimab was well tolerated with no unexpected safety issues and only mild to moderate adverse events. Next. So as take-home messages, we have that sonelokimab achieved further improvements by week 24, including outcomes in the joints, skin, and patient-reported outcomes as measured by the PSA-12, and that it maintained a favorable safety profile. Of course, this data needs to be replicated in phase 3 studies. Now going to the second new molecule, talking a little about zasocitinib, which is a new oral TYK2 inhibitor. Just like deucravacitinib, it focuses on the GH2 domain of TYK2, acting as an allosteric inhibitor of TYK2. The main difference is that zasocitinib shows a higher selectivity for the GH2 domain of the TYK2 molecule, because the GH2 domain can also be found in JAK1 and JAK2. So it would have a higher selectivity for TYK2 inhibition, which could potentially improve efficacy and safety. At ACR, they presented several abstracts about it. I'm going to highlight just a few graphs. It was also a dose-ranging study. And you can see on the left that the ACR 20, 50, and 70 responses at week 12 showed greater efficacy with the dosing protocols of zasocitinib 15 milligram and 30 milligrams, sorry, as you can see in the blue bars and red bars. When looking specifically at the skin responses, the PASI responses, only the 30 milligram dosing protocol achieved a higher response compared to placebo, indicating the greater dose response in the skin when compared to the joints. Next. So as take-home messages, we have that zasocitinib, again, which is a new oral TYK2 inhibitor, demonstrated significant efficacy at week 12, particularly with the 30 milligram dose in the skin. And also zasocitinib maintained a favorable safety profile similar to the ones found in the psoriasis studies and in the deucravacitinib studies. And just like sonelokimab, it also needs to undergo phase 3 studies. The fourth abstract I mentioned is about vunekizumab, a new humanized IL-17A inhibitor that was tested in this phase 2 study that was also dose ranging at 2 different dosing protocols, 120 milligrams Q2 weeks and 4 weeks, and 240 milligrams with the same dose interval, looking at ACR 20 responses at week 12. Next. So they looked at 112 patients, and the primary endpoint, which was ACR 20, was met for the 2 dose protocols, 120 and 240. And we can clearly see that for all outcomes, including ACR 20, 50, 70, and PASI, there was a better response when looking at the 240 milligram protocol. The safety, although not shown here, was similar to other IL-17A inhibitors without any new red flags. Next. So as key takeaways of this abstract, we have that vunekizumab, which is a new IL-17A inhibitor, demonstrated significant efficacy at week 12, as shown by meeting the primary outcome and secondary outcomes, especially with the 240 milligram dose. And that just like sonelokimab and zasocitinib, it also maintained a favorable safety profile and also needs to undergo phase 3 studies. Next. Now moving away a little bit from the new medications and talking about 2 that have been around for longer. First one is a study about the safety of secukinumab, now looking at different diseases. So a tool presented at ACR 2024, an updated full data showing the safety across psoriasis, PSA, SPA, and HS, combining a total of 22,000 patients, and really showing the continued safety across multiple diseases. The most common adverse events, the infection ones, showed that most common were nasopharyngitis, upper respiratory tract infection, and headaches. And when looking at adverse events of special interest, meaning infection infestations, opportunistic infections, and tuberculosis-related events, all of those had a very low incidence across time and across diseases. As expected, there was a little bit of candida infections, ranging from 0.9 to 5.6%, but nothing really alarming. Next. And going to more severe and concerning adverse events, we could also see that the incidence of IBD, MACE, suicidal ideation, uveitis, and malignancy also remained low across all indications of secukinumab. Next. So the key takeaways of this abstract is that the pooled safety data really reaffirms secukinumab's efficacy across 69 clinical trials and across diverse patient populations, including psoriasis, PSA, AxSpA, and HS. Next. To finish my highlights, I would like to bring this controversy of methotrexate in combination with biological DMARDs, and whether this increases or not drug survival. So at ACR 2024, another abstract added to this ongoing discussion. This was a systematic review and meta-analysis that initially identified 2,299 records, including 19 in the final analysis. However, only 2 of these studies involved biological DMARDs other than TNF inhibitors, only one with secukinumab and one with ustekinumab. Overall, the combination with methotrexate found superior drug survival with a hazard ratio of 0.81, taking into consideration a heterogeneity of 48%. Next slide. Yeah. Here is just for the visual part of the systematic review and meta-analysis, showing that the combined effect with the diamond favoring combination therapy, but again, keeping in mind that 17 out of these 19 studies were with TNF inhibitors. Next. So the take-home messages of these last abstracts that the combination therapy of methotrexate significantly improved survival biological DMARDs, particularly with TNF inhibitors. And as a result of this abstract, we can really only say with TNF inhibitors, not with other mechanisms. And to verify these observational findings, future randomized controlled trials are really needed to provide high quality evidence to finally answer this question about whether we should combine with methotrexate or not. Next. And that's it. So I'd like to thank you for your attention and open for questions and Atul's comments.
Yes, thank you so much, Andre, and thank you, Atul, for supporting and supervising in the preparation. And I saw that you had your hand up, so I think we can directly start with your expertise here.
Yeah, thank you. I mean, I want to congratulate Andre. Wonderful presentation, crisp, on the point. You stayed in time. It was fantastic. Very, very, very good. And you made all these beautiful slides as well. So congratulations. I'll start from the just quick comments on these abstracts that you presented, from the latest that you presented, your last one, and then going backwards. So I think in my mind, the controversy about methotrexate is not whether it increases the longevity of the drug. If you think about it, the controversy is whether combining methotrexate with a biologic increases the efficacy of the biologic. That's the controversy. And no studies have ever shown that there is increased efficacy. The reason why we are giving it to the patient, of course, yes, we want the drug to last longer. But many people will say, yeah, I would agree that giving methotrexate will reduce the anti-drug antibodies and would keep the drug in the blood longer and last. However, no study has shown that the efficacy of the biologic is improved, as opposed to, say, in rheumatoid arthritis, where a combination of biologic plus methotrexate improves the efficacy. Not shown in psoriatic arthritis. That just a comment, and I would like to hear other people. Going backwards, uveitis is another thing. None of our biologics treat uveitis, not even anti-TNFs. Our biologics prevent new attacks of uveitis. If somebody gets uveitis, the only drug that treats uveitis is steroid eye drops. So we have to be, so I always tell, when presentation, that anti-TNF monoclonal antibodies prevent new attacks of uveitis. However, if somebody is having acute attack of uveitis, we are not going to inject them with a monoclonal antibody of TNF. So just a clarification about these things. Going back, the interesting thing about both the study on sonelokimab as well as the study that you presented with the new TYK2 inhibitor, I'm still confused about what dose are they going to go forward in phase 3 studies, because interestingly, there isn't. Phase 2 studies are generally done to find the correct. You do multiple doses trying to find what the dose is the best, and then phase 3 study, you take the dose forward and do the studies and then go to the FDA or EMA. And interestingly, what was shown in the sonelokimab was the 60 milligram and 120 milligram. There was no dose response. So and we are participating in the phase 3 study, and so and many people on the call might be participating as well. And so it is not and these are already declared phase 3 studies. In one study, they're going with 60 milligrams sonelokimab. The other study, they're going with 60 and 120 both, because they themselves are not exactly sure what dose will ultimately go in front of the FDA. FDA in general, and I don't want to talk about EMA, but I have gone in front of the FDA many times. FDA almost always goes with the lowest possible dose, and it is always a struggle for the drug company to get a higher dose approved, even though we as rheumatologists like to have a couple of choices if the lower dose is not working to go to higher dose. But it becomes difficult because FDA doesn't approve that. Similar thing with that zasocitinib. That is, interestingly, in fact, the higher dosages had on the PASI, the slide that you showed, the PASI scores were lower for the higher dosages, which was very interesting and awkward, I would think. They're also going with the phase 3 study. And it'll be interesting to know that, I mean, it is unclear from the phase 2 studies, which are supposed to clarify what the dosages should be. And the last quick point is we have now, I think the phase 3 study for deucravacitinib is completed by the end of this year. In fact, before 31st of December, some people would know what the results are because it was closed and etc. So that is very close, deucravacitinib to get into early next year, go in front of the FDA, etc. But the point I want to make is, including deucra, there will be 16 novel therapies, 5 anti-TNFs and 3 IL-17 inhibitors, 1 IL-12/23 inhibitor, etc., etc. We are soon going to make a decision where these drugs fit, because if you look at the GRAPPA guidelines, they're all on the same line. If somebody fails, what do you start with? Active arthritis, and all of them are on the same line. But we need some better clarity how we are going to identify patients that I'm going to use this drug and that drug. And just the comment that we are not there yet. This is good to have all these different choices. What we don't have is clarity about where we'll be going with each drug. And congrats again, wonderful presentation.
Thank you
Thanks,
so much, Atul, because I cannot agree more, especially on the brilliant work that was done by Andre, was presenting. And I think Andre, you really showed us existing treatments for extramusculoskeletal manifestations and how they can prevent, to agree also here with Atul, and also new modes of action that could be available for us in the nearer future. And again, I think that Atul made a very relevant point that we are not there yet to have precision medicine really saying in which patient we should start with which treatment. And I think this is also a call for action that we need to aim for, being more specific with our management recommendations. And Sybil, you also had a question in the chat, so maybe you can just jump on the call and also give your verbal comment.
Sure. Maybe not a question, not a real question, but just to emphasize. So most of the trials that were included in the meta-analysis for the methotrexate to be used with biologic therapies actually were negative. They did not reach significance, and it required a meta-analysis to be significant. So maybe we need a very high number of patients to be able to see a difference, which may mean that number needed to treat is pretty high. So whether we use the medication for standard treatment requires the judgments between number needed to treat and number needed to harm. And methotrexate does have a lot of harms as well. It doesn't work for everyone. So I think I fully agree with Atul that it probably not is about immunogenicity. It's about added efficacy of the methotrexate, and it's for the subset of patients and not for the whole patients that are on biologic therapies.
I agree with your point, and also the question of like how many people you need to treat the NNT, and when you do get the positive results, like how many months does it actually change? We don't know that either. Like we don't know pretty much anything about this drug survival part. Most of the studies are negative. The results are driven by a few studies that had a higher number of patients. So we don't have a clear answer on that either. So we don't have a clear answer if it does, in fact, improve drug survival, and if it does improve drug survival, how many patients you need to treat, and when it does improve, for how long does it make a difference? So a really open topic for research.
And I think here again, Martin's perspective as a patient was really important. He wrote in the chat, for patient, it is important to know whether there is evidence for the additional effect of methotrexate, strengthening the effectiveness of TNF-alpha and or prolonging its efficacy over time. And I think Andre just perfectly summarized where we are at the moment, and we can't just give your perfect explanation by now. And yeah, I think this is something that we still have to figure out in a more detailed way, but I think it's quite obvious for all of us that we are here in a different situation in PSA compared to rheumatoid arthritis, where the combination therapy is having very clear evidence to be superior And I think it is on a individual basis for each patient, right? That if there's a reason for us to prescribe additional combination with methotrexate, or if there are any side effects, or if the patient is doing fine with monotherapy. So I think we have to go back and do a more individualized patient-based decision here. Siba, I saw your hand up as well. Please join for the Q&A.
So in respect to the issue with methotrexate, in psoriatic arthritis, or methotrexate in psoriasis, and methotrexate in axSpA. So in axSpA, it is not an addition. In psoriasis or psoriatic arthritis, we are treating with methotrexate, and then the biologic is an addition on the top of methotrexate. In axSpA, it is not like that. So in that respect, in this study, which is showing that methotrexate is increasing the longevity of the biologic, makes sense because overall, within 3 to 4 years, majority of the patients have to get the biologic changed, either because of the antibody formation or because of the loss of efficacy. So that was my one comment. And another, the new group of drugs we are getting, TYK2 inhibitors, and Atul has already mentioned that deucravacitinib is already approved in certain conditions and likely to get approved in more. So the issue with the JAK inhibitors, we know the post-marketing study has mentioned the effect on cardiac disease, thrombosis, and cancer. So FDA has now made a recommendation that they have to fail methotrexate. Not only have to fail methotrexate, they have to fail anti-TNF. And then, at least in the United States, JAK inhibitors can be used. But as with the TYK2, so far the signals are not there in respect to its cardiac effect and malignancy. So I think that's a good progress in respect to TYK2. In addition to deucravacitinib, we are getting more drugs, so we'll get more options. So as we are getting more options, so as Fabian and Atul has mentioned, that now I think GRAPPA has to, give a good thought process and come out with a kind of a guideline that once the conventional DMARD fails, which of the other medications will get priority. That kind of thought process from GRAPPA will be very helpful.
Yes, thank you, Siba, for your comment. Do fully agree. And as we are coming close to the end of the meeting, I would like to give the word back to Sybil, because you also had your hand raised, and then I think we can conclude.
Yeah, thank you so much. Very quickly, we need head-to-head trials to be able to come up with those GRAPPA recommendations or guidelines about when to choose what. And a study has been launched to compare IL-17 inhibitor therapy versus an IL-23 inhibitor therapy. So like a superiority trial. So actually, I hope we're going to be able to see some advances in the field that's going to give us some scientific-based recommendations.
Wonderful. Thank you so much for that final comment, and everybody who has participated in today's session. It has been such a rich discussion that I think I'm sure that it has been very valuable for everyone attending today. Fabian, you want to say some last words?
Yes, I think thanks to all the young GRAPPians presenting today and their senior GRAPPA members supervising them and preparing the presentations, but also a very heartfelt thank to GRAPPA administration, and particularly Annie Spengler, for her invaluable support in organizing this webinar. And I think, especially when we are coming to the end of the year, we are wishing everyone a splendid holiday season and all the best for 2025. But we're also looking forward to the next GRAPPA Virtual Congress highlights, because we are going to continue with the post-AAD episode, which will take place in March 2025. And Lourdes, I can only thank you for supporting and collaborating with me on creating this webinar and hosting it so brilliantly today. And thank everyone for your attention and your insightful comments.
See you in March for the next one. Bye, everyone.
Thank you so much.
Thank you very
Thank
much.
you.
Bye-bye.
Thank
Thank
you.
you.
Bye-bye. Bye-bye.
Thanks, everyone. Bye-bye.